A very good afternoon to all of you present. I especially thanks to the all organizing team, as especially Dr. Vitull Gupta and all ma'am for giving me a chance to speak today. So I begin my slides. So I will be talking today on the diabetic kidney disease. So what is exactly diabetic kidney disease? As such, there is no widely accepted definition for DKD, but as such, for the American Diabetes Association, it is usually a clinical diagnosis that is based on the presence of albuminuria or reduced estimated GFR in the absence of signs or symptoms of other primary causes of the kidney damage. So diabetic kidney disease is a serious matter. Kidney disease is a frequent diabetic complication, as we all know, as it occurs in 30% in type 1 diabetic patients and 40% in type 2 diabetic patients. So diabetes is most common cause of CKD and end-stage renal disease in developed as well as in developing worlds. It also amplifies the cardiovascular disease risk. So as for diabetes is one of the leading cause of the CKD, we all know, and the prevalence of the end stage CKD is 10 times higher in people with diabetes, and 80% is the cause of the end stage renal disease that is caused by diabetes, hypertension, or the combination of the both. So in this scenario, the screening of albuminuria should be done every yearly after the diagnosis in people with type 1 diabetes or type 2, and the similarly and the same after first 5 years in people with the type 1 diabetes. So if we're talking about what is the residual risk and the cardiovascular in type 2 diabetes, as such, you can see in this, the diabetes mellitus is coincident with this cardiovascular disease risk to the tune of 12.3 to 15.3%, and the diabetes mellitus is also leading in the prevalence of the CKD to the tune of 48.4%. And there are many contributors to this excess risk, because this chronic kidney disease, it is all we know that a CV risk multiplier, because limited treatment options are there. Then the heart failure could be there. It goes under recognized as the diabetic complications, and limited preventive care strategies are there. So if we see in this slide, we see the natural course of the history of diabetic kidney disease. In the years, you can see 2 year, 5th year, 10, 20 and 30 years. Initially, in the first 1 to 2 years, there will be the signs and symptoms of hyperglycemia, GFR could be raised, normal. And initially, when we see pathological, there could be cellular injury leading on to coming years mesangial expansion with the glomerular sclerosis or tubular diseases. And initially, after the 5 years, you can detect in the patients there could be microalbuminuria. GFR could be normal at the stages, and the other concomitant hypertension could be detected. And next, over 5 to 10 years, you can assess for the cardiovascular diseases. Other with the GFR can be declining low. Instead of microalbuminuria, you can have the macroalbuminuria in your patients. And the pathological changes may be always increasing from the cellular injury to tubular interstitial fibrosis, along with some inflammation, and leading on to kidney complications, and along with the end stage renal diseases. This occurs over the lifespan from diagnosis up to the 30 to 35 years. So our target is we have to always halt the disease progress. There is as such no cure for CKD, or the diabetic kidney disease can be itself prevented, or it can be, the disease process can be halted. So I will be coming in the next slides how it could be achieved. So there is a mechanistic link between pre-diabetes, diabetes, and diabetic kidney disease and the end-stage renal disease. So there is always a risk, this link between pre-diabetes, diabetes leading to the chronic hyperglycemic changes because of metabolic syndrome, dyslipidemia, increased fatty acids, this metabolisms. There could be hemodynamic changes leading on to cascades of inflammation, cytokines and chemokines leading to oxidative stress, then leading to apoptosis, autophagy, mitochondrial dysfunction or the mitophagy, leading on to the diabetic nephropathy. And all these things lead to, again, to the end stage kidney disease. This is a mechanistic link between the pre-diabetic diabetes and this nephropathy, along with end stage renal disease. So this is a healthy glomerulus. You can see fenestrated epithelium is well appreciated, mesangium is there, basement membrane is there, podocytes are there. Then the diabetic, when there is diabetic kidney disease, what happens? There is a thickening of the basement membrane, that is the blue darkened. Then the mesangial expansion is there, and there is a loss of fenestration in glycocalyx, and then the podocyte injury and the loss of the tissue is all appreciated. So this is again structural changes in the diabetic kidney diseases. Then what does the diabetes damage do to the kidney? It affects mainly direct glomerular damage could be there, or the direct tubular damage could be there. In both of the scenarios, there is albuminuria, leakage of the albumin inside the urine. So there is a podocyte barrier damage when there is a direct glomerular damage leading on to glomerular leaks, and if there is a direct tubular damage, it leads to decrease in albumin endocytosis, leading to the reduced retrieval, and again leading to microalbuminuria, and again the vascular imbalances, then leading to the hyperglycemic. All is the cascade that is the damage in the diabetic kidney disease. So this is again one of the pathological model we all had discussed. So what are the other diabetic complications which is associated with this diabetic kidney disease? Once the patient is diagnosed with diabetic kidney disease, so he or she could be having some of the other complications in the later lives. There could be cerebrovascular coronary artery disease, that could be diabetic cardiomyopathy, peripheral vascular disease, foot disease, bladder dysfunction, neuropathies, erectile dysfunctions, eye diseases, periodontal diseases, along with depression and anxiety, leading all to cascades of the cognitive impairments. So the other complications, it could be increased risk of UTI, serum electrolytes, acid-base complications could be there, type 4 RTA, that is hyperkalemic and low in iron gap. They are more common in diabetic kidney disease patients. Even the kidney stones are more common in patients, especially those with moderate renal dysfunction. Even this low urinary pH, that is more, and it leads to the uric acid stone. These are one of the complications of diabetic kidney diseases. Now what to do? What is the CKD screening and the diagnosis people for living with the diabetes? So who and when to screen? Yeah, when the patients come to you with the type 1 diabetes, start immediately screening for albumin, yearly starting and 5 years after the diagnosis in type 1 diabetes, and in case of type 2 diabetes, yearly starting at the diagnosis, and again thereafter annually. How to screen? You need to get a spot urine ACR, that is albumin creatinine ratio, and the estimated GFR. So what to do? When the test is positive, then we need always to repeat and confirm. We need to again evaluate possible temporary or the spurious causes, and then we can always consider using cystatin C and creatinine to more precisely estimated GFR, and only persistent abnormalities define the CKD, and we should always initiate this evidence-based treatments. So what exactly defines your diagnosis for the CKD? There could be persistent urine ACR, that is more than or equal to 30 milligram per gram, or persistent estimated GFR, it is less than 60 ml per minute, and over other evidence for the kidney damage. So I had discussed the screening for microalbuminuria. You can see the microalbuminuria, second normal and micro, and then came macro. So the microalbuminuria is, you should be always repeat 2 times over 3 months, and you should be always confirming albuminuria if 2 out of the 3 tests are positive. And in case of macroalbuminuria, that is also called proteinuria. In the case of females, it is labeled as when it is more than 35, and in case of males, it is more than 25 milligram per millimole. And in this case, we need to quantitate. We need to collect 24-hour urinary protein and quantify the protein excretion, and we need to get a protein creatinine ratio. So there are certain factors which affect your urine albumin excretion. For example, in case there could be increased fallacious or spurious, for example, in strenuous exercise, poorly controlled diabetes mellitus, even in heart failure, UTI, acute febrile illness, uncontrolled hypertension, hematuria, menstruation, even in pregnancy. And there are certain conditions in which there could be decreased AER, that is patients when on NSAIDs or ACE inhibitors. So these should be always kept in mind before labeling the patient as to be microalbuminuria, it is true or it is false. So what are the other biomarkers? These are the latest biomarkers associated with predicting for the diabetic kidney disease. For example, when we suspect there is inflammation or endothelial damage, or there is fibrosis, we need to get some of the biomarkers at the level of glomerulus, similarly proximal tubules, loop of Henle, distal tubules, and the collecting ducts. For example, inflammatory to the endothelial damage or the vascular damages, there we always get alpha-1 antitrypsin levels, TGF beta-1, MCP1, VEGF and other markers, glomerulus for cystatin, C-alpha-1 microglobulin and the beta-2 microglobulin along with albumin. Then the PCT, there Kim and Nagel, and along with distal tubule again the similar, that's osteopontin and uromodulin for the loop of Fenley and copactin for the collecting ducts. Now, what are the symptoms of DKD? The patients will be coming, they will be saying they are passing the foamy urine, there is frothy urine, and there is unexplained proteinuria. Patient will be feeling fatigue, there will be unexplained edema, or any associated, you could fetch the peripheral vascular disease or could be hypertension, coronary artery diseases. So I had already discussed how you will diagnose them when there is impaired estimated GFR less than 60, there is albuminuria, that is UACR is more than 30 milligram per gram creatinine, and it is always spot sample to calculate the ratio of albumin to creatinine. Morning sample is preferable, and the annual screening is always very important in diabetic kidney disease, that is 5 years after the diagnosis with type 1 diabetes and upon diagnosis in case of type 2 and then yearly afterwards. So if we look for the stages of diabetic kidney disease, there are 1, 2, 3, 4 and 5 stages as such. In the stage 1, there is hyperfiltration along with nephromegaly. GFR could be normal, elevated. Even the albuminuria could be absent and BP can be normal at the time of diagnosis. Stage 2, that is GFR could be normal or even high, and albuminuria is absent. The BP could be normal and time of illness is less than 5 years. Stage 3, here it comes the microalbuminuria, and it is incipient nephropathy is there. Albuminuria ranges between 30 to 300 milligram per day. You always remember DKD can be even reversed till stage 3. Then comes your stage 4 where there is macroalbuminuria and there is declining in the GFR, and comes the later stage, that is CKD stage 5, in where the GFR is diminished and the albuminuria is decreasing. And the time course of the illness, it is 15 to 30 years after diagnosis. So it is a CKD risk progression. In this you can see there is various categorization according to the GFR, that is G1 to 3A, 3B, 3G4 and G5, along with albuminuria categorizes into A1, A2 and A3. So it is again we need to step up the where should we screen the patient, and the yellow part shows you need to treat the patients, and the orange part is like we need to treat and refer the patient, and then it should be aggressively treated, as well as the proper monitoring should be done in the coming years. So let's talk about how to manage this diabetic kidney disease. You know, the aim is all to slow down the progression of the kidney damage. We should always target onto proteinuria to decrease this proteinuria, hypertension to control hypertension by many drugs or 1 or 2, or decrease this glycemic levels or the target on the hyperglycemic. So for overcoming barriers to management of the CKD in patients with diabetes, there are various multidisciplinary education, harmonized clinical practical guidelines are there, self-management programs are there. There are various care models and risk mitigation strategies to improve management of diabetes and this CKD. So there is multifocal approach. Number 1, we need to slow down the progression of diabetic nephropathy with the optimal glycemic control. The target should be HbA1c should be less than 7%. In case we should be starting with intensive antihypertensive control when the blood pressure is to target less than 130 to 80 for people with proteinuria, which is less than 1 gram per day, and BP should be targeting in those cases where the proteinuria is more than 1 gram per day, it should be less than 120/75. Then you need to start with blockage of RAS for the ACE inhibitors or ARBs to control this proteinuria. So this is a pyramid where we can see that starting from the base, we need to exercise, we should be cutting off excess salt, and nutrition should be controlled, smoking cessation should be done. Even in all the patients you need to control your lipid management, blood pressure, glycemic controls. In most of the patients you should be starting with RAS blockage agents with SGLT2 inhibitors to control the glycemic status, and in some patients you need to take care of this vascular damage when we start the antiplatelet therapies. So targets for incipient and overt diabetic nephropathy, we need to lower the blood pressure to target of less than 130 to 80 mm of Hg. We need to block the RS because by using ACE inhibitors or ARBs to maximum tolerated doses. Then we need to improve the glycemic state, and we should be targeting with less than 6.5% by using the insulin injectables, and when we should be targeting to lower the LDL levels to less than 100, and anemia management should be done to the targeting between 11 to 12. We can use erythropoietins or plus oral injectables as well, and the endothelial protection we use to aspirin we should starting daily, and smoking should be cessation. The glycemic monitoring and target, we should be always HbA1c. If we are targeting less than 6.5, then the severity of CKD will be lesser, macrovascular complications will be absent, comorbidities will be few, and life expectancy will be good as compared to if the targeting HbA1c is less than 8. Then in the similar scenario, the life expectancy will be short, comorbidities will be many, and resources for hypoglycemic management are also impaired in such scenarios. So in this scenario, the physical activity, nutrition and weight loss, we should be in all the patients of diabetic nephropathy or diabetic kidney disease, and the first line therapy should be metformin. Now metformin should be used always when the GFR should be more than 60, and if the GFR is less than 45, you should always reduce the dose of metformin, and you should discontinue metformin when the GFR is less than 30. Or in case of kidney failure, when there is SGLT2 inhibitor, when the GFR is less than 30, we should not initiate such. And in case of kidney failure also, SGLT2 inhibitors, they are not initiated. You can use additional drug therapy needed for glycemic control like GLP-1 receptor and agonist are preferred, DPP-4 inhibitors, insulin, even sulfonylurea is good enough, and alpha glucosidase inhibitor. And again, this is a slide which you can see the drugs: metformin, SGLT2 inhibitors, GLP-1 receptor agonist, DPP-4 inhibitors. So in this slides, you can see that SGLT2 inhibitors and this DPP-4 inhibitors, they are safer in type 2 diabetes with CKD across the patient profile. So if we discuss what about the transplantation in the diabetic kidney disease, transplantation is always superior in dialysis in terms of patient survival, because living related donor provides excellent results, and it has been found in many studies that patients with end stage renal disease due to diabetic kidney disease who receive transplantation will have projected life expand to 19 years as compared to 8 years for those who remain on the dialysis. And how to prevent this diabetic? We should always be maintaining or target HbA1c less than 7. You should be controlling hypertension. We should avoid potential nephrotoxic drugs and substances. Early detection and optimal management of diabetes should be done, and the regular follow-up should be managed. So I will be discussing about what are the latest advances and research. These are my last slides, and in this I would like to say there is one molecule, that is finerenone, that is a non-steroidal mineralocorticoid receptor antagonist. What it do, it reduces the kidney failure and disease progression in the diabetic kidney disease, and the trial demonstrated, and it is to be taken in the single dose of 10 mg or 20 mg orally once daily, and its adverse effects are generally hyperkalemia, hypotension or hyponatremia. So there is another trial, that is a carmilena, that is a long-term CV and cardio, this renal safety of linagliptin. Linagliptin also safe molecule to be used. It also slows down the progression of diabetic kidney disease. It is used is a 5 mg per day dosage. Along with this, dapagliflozin is also wonder drug. It is also used as a 10 mg per day. It also reduces to this diabetic kidney disease. Along with it also reduces the risk potential of cardiovascular events in patients with chronic kidney disease. The SGLT2 inhibitor, that is dapagliflozin, it is based on the results of DAPA and the CKD. There are various with the heart failure patients also it is safe, and all in the CKD patients it is also safe. So if it is the first line drug therapy in case when there is the cardiac patient is there or the other more progressive diseases there, so it is always safer. So this new drug is again approved, that is a vaxagliflozin, that is 20 mg. It is a sodium glucose co-transporter 2 inhibitor indicated as an adjuvant to diet and exercise to improve glycemic control in adults with type 2 diabetes mellitus. This is a new device approved by the FDA, that is the MiniMed 780G system, an automated insulin delivery system that helps people ages 7 or old. It manages their diabetes by detecting trends and tracking patterns in glucose levels through continuous monitoring, using an insulin pump to automatically deliver insulin and adjust the amount of insulin delivered. So this is again one of the slide we shall go in brief, that is albuminuria in the diabetic kidney disease and non-albuminuric diabetic kidney disease. So in albuminuric diabetic kidney disease there is always a microangiopathy, whereas in non-albumin there is macroangiopathy. So in this case this albuminuric diabetic kidney disease, you will see there will be more patients with glomerulosclerosis, whereas in other setup there will be tubular and vascular damage. So there are a lot of historical perspectives on slowing of this diabetic kidney disease or CKD progression starting from 1980 to the 2022. There are a lot of trials which have been suggested and summarized all the drugs. So the key updates are, there is evidence that people with poorly managed hyperglycemia associated with type 2 diabetes can also be effectively treated with sulfonylurea, GLP-1 receptor agonist and dual GIP. And GLP-1 receptor agonist and the teriparatide have additional benefits over insulin and sulfonylurea, especially lower the risk for hypoglycemia. And the results from the comparative effectiveness meta-analysis suggested that each new class of oral non-insulin agents added to initial therapy with metformin generally lowers the HbA1c level to 0.7 to 1%. And if GLP-1 receptor or the dual is added, then it is more than 2% lowering of HbA1c is expected. So particularly important, as SGLT2 inhibitor and GLP are associated with lower risk of hypoglycemia and individuals with atherosclerotic related cardiovascular disease, heart failure and the CKD. So the carry home points are, advanced CKD is high risk clinical entity with high morbidity and mortality. CKD doubles the risk of cardiovascular events and death in patients with type 2 diabetes. It's never too late to improve glycemic control, but strategy is different. CKD should be considered when choosing an anti-diabetic drug, avoiding the hypoglycemia, and many changes in treatment are needed, making management challenging. SGLT2 inhibitor dapagliflozin reduces CKD progression and heart failure patients and other cardiovascular disease risks. And non-steroidal MRI inhibitor already discussed, that is finerenone, should be thought of an adjuvant therapy to slow nephropathy progression. And GLP-1 receptor agonist like liraglutide, exenatide and semaglutide also reduces CV risk and are safe. So additional BP control is very important, but challenging and novel approaches are really needed to improve the prognosis. So here I end up my slides, and thank you all for your patience listening. Thank you.
Thank you very much, Dr. Aman Bharti. You have done justice to the topic. And I think recently SGLT2 inhibitors have revolutionized the diabetic kidney disease for prevention as well as treatment.
Yeah.
Thank you very much.
Thanks a lot, sir. Thanks.